Welcome back to the equine anatomy lectures. Today we will continue with this topic by discussing the equine neck. Um, in this lecture, what I will talk about is how important this topic is for us as veterinarians. Then I'll talk about the muscles of the neck, the fascia, both the deep and the superficial, and then the structures that are associated with this fascia, and then the lymphatics of the neck, and then we'll talk about the nuchal ligament, then the cervical vertebra. So these are the six topics that I will be covering during this talk. First, we'll talk about the significance. Why should I study the anatomy of the equine neck? Well, the reason why you want to study the anatomy of the equine neck is because you will encounter a number of extremely important both procedures and clinical cases in the equine. For example, you can see where do we do a venopuncture in the jugular vein. If you don't know the anatomy of this area, you won't be able to to put your catheter or to draw some blood for different clinical usages. Number of infections, number of burns that we need to be aware of in the equine neck. Clostridial infection, for example, in the left-hand side picture, there's an accumulation of gas and underneath the skin, subcutaneous. So we have to know what's involved, what structures are involved, so we won't injure them. Basically, same thing with the right-hand picture that you see a number of structures being involved in the after a burn and things like that. So anatomy of the neck is an extremely important topic. After I convinced you that studying the anatomy of the neck is extremely important for us as clinicians, it becomes important to start knowing what are the structures of the neck. And the very first thing that we're going to encounter are the muscles of the neck. So I'm going to talk about the muscles from a clinical standpoint. Only the muscles that are clinically relevant will be covering. The rest, you've learned them in small animals, so there's no need for me to re-mention them again. So we have, for example, number 7 is the rhomboideus. Number 9 is the trapezius muscle. Number 8 is the splenius muscle. Number 11 is the serratus ventralis cervicus. Number 13, where the laser pointer here is the omotransversarius. And number 14, this very long muscle right here, is the brachiocephalicus. And the brachiocephalicus, just wanted to mention that it has two parts. The first part is the cervical part, and the second part is the thoracic part, or the humerus part, if you will, where the humerus is. So the cervical part of the brachiocephalicus is called the cleidiomastoides, whereas the humeral part is called cleidiobrachialis. We will talk about the muscle in a second, but we have the cutaneous coli here, number 17. We have also the sternocephalicus, number 15, and we have number 16, the omohyoides, the omohyoides. So let's talk about these muscles again. First, we have the rhomboideus, number 7. Second, we have the trapezius. Third, we have the serratus ventralis cervicus. After that comes the omo transversarius. After that comes the big brachiocephalicus, which consists of two parts. The cervical part we call cleidiomastoides, and the humerus part is called cleidiobrachialis. After that comes the cutaneous coli, a V-shaped cutaneous coli, then the sternocephalicus, and after that the omohyoides. So this is basically these are basically the muscles of the neck, the superficial muscles at least of the neck. And we'll talk about how clinically important these muscles are. Now, bilateral action of the brachiocephalicus muscle flexes the neck ventrally, as you can see in the left-hand side picture. So that is due to the bilateral action of the brachiocephalicus muscle. Now, unilateral action bends the neck toward the active side. So if the right brachiocephalicus muscle contracted, then the neck will be bent toward the right-hand side. If the left brachiocephalicus muscle contracted, then the neck will be bended toward the left-hand side. Now, when the neck is flexed, like the right-hand side picture, when the neck is fixed on its position, the unilateral action of the brachiocephalicus muscle advances the limb, as you can see in the right-hand side picture. So the bilateral action flexes the neck ventrally. The unilateral action will flex it or bend it toward the active side. And if the neck is fixed in its position, then the unilateral action will advance the limb of that side. So if the right brachiocephalicus muscle is flexed in a fixed neck position, then the right forelimb will be advanced. On the other hand, if the left hand side brachiocephalicus contracted, when the neck is fixed in its position, then the left forelimb of the horse will be advanced. These are the two functions or the three functions of the brachiocephalicus muscle. The bilateral action flexes the neck ventrally, yet the unilateral action bends the neck to the active side. If the neck is fixed, then the unilateral action of the brachiocephalicus advances the limb. These are the three functions of the brachiocephalicus muscle. Now, we took some of the muscles out, and we can see here the rhomboideus, and we can also see the huge splenius muscle, the big splenius muscle. Also, we can see the serratus ventralis, cervicus, and sternocephalicus, and also the omohyoides, which is number 10. Number 10, omohyoides. Now, you can see how thick and muscular the splenius is. This is very important from a clinical standpoint. Also, you can see how the sternocephalicus, which is number 11, is basically providing a bed, a complete ventral border for this big vein, which is the jugular vein. We will talk about that in a second. But this is just to show you some of the clinical relevances of these muscles. This is a ventral view to show you the ventral aspect of the neck, and mainly to provide you with a clear picture of what the cutaneous coli, the V-shaped cutaneous coli, is doing. It's covering not only the jugular vein, but also the cephalic vein and a number of other structures, lymphatic center and things like that. We will talk about in a second. But this is also to show you the importance, the clinical importance of these muscles. Remember that we have jumpers, horses that jumps, and usually when they jump, they have a tendency to injure this area, the pectoral area. Of course, if we are not very careful as veterinarians, then the big old veins, these jugulars and cephalic, can be ruptured and severe bleeding can happen. So we have to understand what's going on with the anatomy of the neck. This is very important. So now, one of the things that I just mentioned is the big old splenius muscle. You can see it on the right hand side picture here, number 8. And on the left hand side picture, you see the area encircled here in the intact horse, in the intact skin. The muscles are not shown, but even though you cannot see the muscles, you know that this area where actually most of your intramuscular injection in the horse are done, basically your needle will enter one big muscle, and that is the splenius muscle. The splenius muscle, which is number 8 in this case. You will see how big the muscle is, and you can see that it is almost free of vital structures. Now, even though we want to give this injection in this site, we will need to be extremely, extremely, extremely careful from two main things. The dorsal branch of the accessory nerve runs in that area. The dorsal branch of the accessory nerve, it supplies the trapezius, the omotransversalis, and the brachiocephalicus muscles. The dorsal branch of the accessory nerve supplies the trapezius muscle, the omotransversalis muscle, and the brachiocephalicus muscle. And I just mentioned a second ago, what's the importance, for example, of the brachiocephalicus in turning the neck, or in flexing the neck ventrally, or advancing the limb. Now, always remember that with any injury to the dorsal branch of the accessory, these three functions might be compromised on the side of the injection. Any injury to the dorsal branch of on either side of the neck might compromise the function of the three muscles that I mentioned. These are very, very important. In addition to that, you have a deep cervical artery that I'm going to show you in a second, and injuring that cervical artery, or branches even of the cervical artery, might cause hematoma, which means an accumulation of the blood under the skin, which gives a pretty unpleasant appearance to the neck of the horse. And some of you uh, may know that showing horses is pretty important, and you don't want your animal to have a lump or swelling on one side of the neck. So we have to be careful, and that's why veterinarians, or horse veterinarians to be specific, they alternate the injection side, the intramuscular injection side. Sometimes they give it in the hind limbs, and sometimes in the right side of the neck, sometimes on the left hand side of the neck, and so on. They choose a big muscle that can handle the needle. Same thing with the cervical artery. Now let's see what these structures look like. Um, Before I talk about the picture, I would like to thank my good friend and colleague, Dr. Ray Will Hyde, for providing this and a number of other pictures. Um, they did such an outstanding job in dissecting the neck of the horse. Now this picture shows clearly the dorsal branch of the accessory nerve, which, as I mentioned earlier, supplies the trapezius muscle, the omotransversalis muscle, and the brachiocephalicus muscles. And we have to be very careful when we give the injection in the splenius muscle, not to injure this dorsal branch, because we don't want to paralyze those muscles. And of course, if we have a dorsal branch of the accessory, then we must have a ventral branch, as shown in this picture. This is the ventral branch right here, ventral branch of the accessory nerve. And the ventral branch of the accessory nerve is important also because it supplies the sternocephalicus muscle. The sternocephalicus muscle is right here. The sternocephalicus muscle is right here. This is the tendon of the sternocephalicus. This is the linguofacial vein. And this is the ramus of the mandible. Ramus of the mandible. This area right here, we've talked about it before, is the Vyborg triangle, where you can access the guttural pouches from this area, and even the larynx you can access from this area. Now back to the ventral branch of the accessory nerve. It supplies the sternocephalicus, and not only this, but also it provides a good treatment option for a behavioral case that's called crib biting. Crib biting. It's like an obsessive compulsive disorder in humans, that the horse start biting on the crib. It's a bad habit. It's a behavioral problem. Now, Why do I mention this behavioral problem? I mention it because part of the treatment, and I'm going to talk about this treatment, it's called the modified fossils technique, is cutting the ventral branch of the accessory nerve. This is neurectomy. We call that neurectomy, severing the nerve. Now, not only this, but also this nerve or this branch of the accessory nerve, the ventral branch, can be utilized in the diagnosis of an important neurological disorder in equine. It's called equine motor neuron disease. So, first of all, the ventral branch can be utilized as one of the treatment options for crib biting, and I'm going to show you what does crib biting look like, and then in the diagnosis of equine motor neuron disease. So let's take a look at a crib biting case. This is a crib biting case. The horse keeps biting on the crib, biting on the crib, biting on the crib until you have the sternocephalicus is right here, and the omohyoides is basically pretty hypertrophied. This is basically a pretty bad habit, and in order to prevent the horse from doing that, we do a modified fossils technique. This is one of the surgical procedures to prevent crib biting. What we do is we cut 10 centimeters from the ventral branch of the accessory nerve. And then what we do is we cut 30 centimeters from the omohyoides and the sternohyoides muscles. Omohyoides and sternohyoides muscles. And then cut the nerve here. And then we cut also the sternothyroides. Sternothyroides. And then the trachea will look like this, with no muscles on it. That in itself will prevent the horse from biting on the crib again. This is basically where the cutting happens. The combined sterno and omohyoides muscles, we take 30 centimeters of each of them, beside cutting the nerve as well as part of the modified fossil technique. Now, we come back to the cutaneous coli. I mentioned earlier that it's a V-shaped muscle that covers, if you will, a number of important structures. This is the cutaneous coli, a V-shaped muscle that covers a number of important structures. So what are these structures? Jugular vein is one of them. Cephalic vein is another. The deltoid branch of the superficial cervical artery. Caudal deep cervical lymph center. We will talk about that when we talk about the lymphatic system of the neck. And then the thoracic inlet. All of these are important structures that the cutaneous coli will cover. The jugular vein, cephalic vein, deltoid branch of the superficial cervical artery, caudal deep cervical lymph center, and the thoracic inlet. Let's take a look at injury of that area where you actually cut the cutaneous coli. I mentioned earlier that jumpers have this problem. This is another beautiful dissection of Dr. Ray. And in this dissection, you will see the cephalic vein in the pectoral area and also the jugular that are covered by the V-shaped cutaneous coli on both sides, of course. But when the horse runs and sever this area, lacerates this area, all of these structures are basically in 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 harm way. This is the caudal deep lymph center that we will talk about also when we talk about the lymph centers of the equine neck. But jugular vein, cephalic vein, deltoid branch of the superficial cervical artery, all of these vessels, in addition to the cervical lymph center and also the thoracic inlet, are very important. When a horse lacerates the pectoral region, injuring the cutaneous coli muscle. In addition to that, we have the junction. We have the junction between the head and the neck. The junction between the head and the neck contains a very important structure that we mentioned a whole talk about it last time, and that is the guttural pouch. The guttural pouches, and how can we access it? How can we access it from the neck? We mentioned if the guttural pouch is infected with empyema, tympani, mycosis, melanoma, chondroids, etc., we have to access it to drain it. And the way to drain it is using the Vyborg triangle. Beautiful pictures of Dr. Ray. We mentioned the linguofacial vein as the ventral border for the Vyborg triangle. The tendon of the sternocephalicus is the dorsal border of the Vyborg triangle, and then the ramus of the mandible as the cranial border of the Vyborg triangle. This is the triangle right here, where the laser pointer is. So the borders for the Vyborg triangles are cranially the ramus of the mandible, ventrally the linguofacial vein, and dorsally the tendon of the sternocephalicus. And this is the Vyborg triangle right here. Now we move to our third bullet in the discussion, and that is the cervical. Cervical fascia are two kinds. We have the superficial cervical fascia, and we have the deep cervical fascia. Superficial cervical fascia and deep cervical fascia. Let's talk about each one by itself. The superficial cervical fascia is loose connective tissue that covers or protects superficial muscles of the neck and jugular groove. So it's loose connective tissue that protects superficial muscles of the neck and jugular groove. On the other hand, the deep cervical fascia are regular, dense connective tissue, pretty strong connective tissue, not loose, and protects carotid sheath, trachea, and esophagus. So, the superficial fascia is loose connective tissue that protects the superficial muscles of the neck and the jugular groove, whereas the deep fascia is dense regular connective tissue, pretty strong, that protects carotid sheath, trachea, and esophagus. Next time, I will be talking in details about each of these structures. What do they do? What do they protect? And how do they communicate?